In the next piece rest, this is the PL tendon. We have dissected it about half of the muscle belly underneath. This is the FCR tendon, and we have also dissected, mobilized it from the lower half of the muscle belly. We will be flexing this wrist so that the two tendons can be divided at the level of the distal flexor crease of the wrist. The most difficult part of it is the harvest of the PT tendon, which is the Pronator teres. That is a deep tendon which is short and is very deep, and the typical area where it gets inserted is the junction of the proximal 1/3 with the middle 1/3 of the radius. And we have mobilized the overlying BR, the overlying ECRL, and then we have harvested this tendon from this insertion at the radius. The important thing is to harvest about 4 centimeter long periosteal sleeve from the radius, and this is how the raw part of the radius can be visualized. We have harvested this periosteal sleeve with careful dissection using the surgical blade. Thank So these are our donors. This is the Palmaris longus. This is the FCR. Now deeper down we are having this one. This is the Pronator teres, which is coming from the ulnar side and is inserted onto this radial side, and this is a small but powerful muscle. This is PT. We have denuded, we have harvested it along with 4 centimeter long periosteal sleeve. This raw area of the radius indicates the area from where we have carefully dissected it off. So these are the 3 donors. Now on this side we have rerouted the EPL tendon, which is here now, and once we move it, it will extend the thumb. The other donors on this side are the other recipient areas. On this side is the EDC. All these are the tendons which are here. This is the area where we have opened just above the extensor retinaculum, and these are the tendons of the extensor digitorum communis. So we are ready for the transfers. So it is a case of radial palsy with wrist drop. We have done the standard triple tendon transfer, and we have used the FCR set of transfers. We have harvested Palmaris longus, we have harvested FCR, we have harvested Pronator teres, and the functions which we are trying to restore is the extension of the wrist, where we have motorized the ECRB with the PT, and second is the extension of the MCP joints of the fingers, where we have transferred the FCR to the EDC, and the third is the extension and radial abduction of the thumb by transferring PL to the EPL. So we have made 3 tunnels subcutaneously. First tunnel distally on the radial aspect of the wrist is for the transfer of the PL to the EPL, which is here. The second tunnel is subcutaneous again, where the transfer of FCR to the EDC has been done.
अभी तो पार्टी शुरू हुई है.
The third is the That is the PT to the ECRB, which is here. So we have done all the transfers. Now we have to tenodesis test in order to check if it is too loose or too tight. With extension of the wrist, we should be able to bring these fingertips to the palm. If we were not able, it means it is too tight. Now with the wrist flexion, all these fingers should automatically go into full extension. If they were not able, it means it was too loose. Analyze the process of holding and picking up an object by the hand in a normal situation. This action is effected in 4 phases. In the first phase, there is opening of the fingers and the hand around the object. In the second phase, the fingers and the thumb surround the object. In the third phase, the object is held firmly by the hand. In the fourth phase, the wrist moves in order to effect a useful movement of the fingers in the desired direction. Let's analyze all these phases one by one in detail. In the first phase, there is opening of the fingers around the object. This is the function of intact long extensors and the intrinsics. And this action would be compromised if there is radial palsy or palsy of the intrinsics. In the second phase, the hand surrounds the object to be held. This requires the function of intact long flexors and intrinsics. Understandably, this would be compromised if there is low ulnar palsy or a combination of low ulnar and median palsy. The third phase requires firmly holding the object to be grasped. This required the strong action of long flexors. This phase would be compromised if there is high ulnar and high median palsy. The fourth phase requires a stable and intact wrist, and this is the function of the high radial nerve. If the high radial nerve is having some lesion or palsy, this function of extension of wrist would be compromised. Thank you.